So tonight on the call, you'll be joined with our guest speaker, Dr. Matt Gittus. Some of you may have come across Matt. He's become a good friend to PKD charity, and he's based at Sheffield at the Kidney Institute there. Good evening, Matt.
Hello.
We've also got Audrey on the call.
Hi.
Audrey is our patient engagement officer, and Audrey, you'll come to know. I'll go later in the summer. I don't want to mention autumn just yet as we launch some of our new research opportunities, and we'll be discussing those with you later on in late summer. So that's Audrey. Jane's not joining us tonight, so that is the team for this evening. We've still got people flooding in. So tonight we are going to be looking specifically at PKD from the aspect of those who are perhaps newly diagnosed. I know there's one or two, and I'll say old hats in the room as well. And it's lovely to have them. As one lady said, she's looking forward to tonight as a refresher in PKD. So for those who are perhaps more experienced, they might find that as well. It's a refresher. So it's lovely to have you. You will have been aware when you come in, we are recording the session. So tonight we're going to, as always, give you our medical disclaimer. Anything we discuss tonight is purely for information only. It doesn't replace any guidance that you're given by your own medical team who know your body and your symptoms. It is a broad brush approach. Remember, you can talk to your high street pharmacist, your GP, and your renal team if you have any concerns. If we want to move on there. And the all important tonight is interactive. The plan for this evening is Matt will give a short presentation. We ask that you do remain muted during that. Thereafter, we will visit questions that you have. Many of us have now got used to Zoom, but I will remind you how you can do it. You'll look and you will see in the middle, it looks like a little speech bubble, and that is the chat facility. You can type your question in there. We can ask it anonymously on your behalf or use your first name only when we ask. Please keep the questions relevant to tonight's topic. We will not be covering other things such as kidney transplantation, family planning in any depth, or diet and lifestyle. We do have plenty of resources available. You may hear us mention them tonight, and we will share the links with you tomorrow. Also, if you're feeling brave, you can raise your hand and we will come live to you on screen, and you will show on a recording. So do bear that in mind. And moving on, Matt, please. What I'd like to do now is hand you over to Mr. Matthew Gittus, and he's going to discuss newly diagnosed with PKD. Thank you, Matt.
Thank you for the introduction, Susan. So, like Susan mentioned, so my name is Matt. I'm a kidney doctor in Sheffield, and I do research with polycystic kidney disease as well. So I'm a clinical researcher, so I'm more people and how systems work rather than sort of lab stuff, really. So I'll be talking to you about newly diagnosed people with PKD, and then these are some of the sort of top tips and some of the key information I think people probably want at the start. So we'll be giving a whistle-stop tour of some of the key points, covering some of the questions that have been raised before the session, and I'll show you where those questions are on the next slide. Let's go. So the contents is separated into 4 sections. So it's into what is ADPKD, what about my family, how will it be treated, and then what about sort of day-to-day life. And any questions that have been asked ahead of time will be in a little bubble on the right-hand side at the top. So I wanted to make sure that all the questions that you did have are covered. So I've tried to make sure at least every single one has got a little bit of a touch on during the talk today. So what is ADPKD? So for people that don't know, ADPKD stands for autosomal dominant polycystic kidney disease. It's a genetic condition, so that means that you can't catch it or get it from anywhere else other than your genes. It's characterized by having multiple cysts in the kidneys, and these cysts are sort of fluid-filled sacs or bags that can develop. And these cysts get bigger over time and they replace normal healthy kidney tissue. And they also can squish the healthy tissue. And this is one of the pictures that's off the PKD charity website, which I quite like. It's showing how the cysts are squishing the healthy kidney in between. There are cysts that you can get in other places, and you can get some other conditions that are sort of linked, but not quite full ADPKD. So that's things like autosomal dominant polycystic liver disease, which has a little bit of overlap, but you don't get the full gamut of what you'd get with polycystic kidney disease. It affects males and females equally. It can affect any ethnicity, and the sort of onset of cysts is usually around 30, 40 years. Some people can get cysts a lot younger than that, but around 30, 40, you should have cysts that might be making symptoms. And it can be that you are in a long family of people that have had problems with polycystic kidney disease, or you could be the first person. And I'll get onto that in the next few slides. And then in terms of how common it is, so I've put something in for both people. So on the left-hand side, you've got Wembley Stadium, and on the right-hand side, you've got the O2 Arena. So in the sort of population of the people that are in the Wembley Stadium, around 36 people would have polycystic kidney disease. And on the right-hand side, about 8 people out of the O2 Arena would have ADPKD. So roughly in the UK, it equates to up to 70,000 people. So it's a rare disease, but it's a common rare disease. And the genetics, so when we talk about genetics and we talk about genes, the way I like to think about it is like a recipe book. So it's a recipe book or a recipe within a recipe book telling you how to make a cake. So in ADPKD, one of these recipes has got a typo. So instead of saying that you're going to add a teaspoon of sugar, you add a tablespoon, something like that. So you still at the end, you'll get a cake, but the cake might not be quite what you expected. And in ADPKD, this typo is what causes cysts to develop over time. And again, I'll show you a little bit about that in a bit. So having autosomal dominant means that you only need one copy of this typo to have the condition. And there's more details about the genetics that I'm going to touch on the PKD charity website. So I put a link to a QR code to the website where it's got all the different recordings on there. And there'll be more of these as we go along. So if you want to take a picture of the QR code or scan it with the camera, that's probably the best way to do it. And the genetics of ADPKD, it's mainly caused by 2 genes, so PKD1 and PKD2. So these were identified a while back, so in 1980s for PKD1 and then 1990s for PKD2. But it does get more complex. So most people will have PKD1 or PKD2 being the cause of their ADPKD. But you can have other ones. So there's other variants that have been found as sort of time's gone on. So these are things like GANAB, IFT140. There's lots and lots of different versions, and there's always more being found. And sometimes people can have all the signs of ADPKD, so have cysts and present like how you'd expect someone to. They have the genetics and it says no mutation detected. And that means you've probably got one of these other variants that we don't quite know about. But it's difficult to know if which category you're gonna fit into without having the genetics. And then finally, someone asked about, they said, I have been told that half of my chromosome gene cells have 0.1% in my DNA. So they were talking about not having all their DNA being affected by ADPKD. That can sometimes happen if you have something called mosaicism. So it depends when the cells are dividing, when you've first been created, if you get a mutation that's after one of the first few cells, only the cells that have after that would then be affected. So you'll end up with a mixture of some cells that have no variant, no ADPKD, and some cells that would have some ADPKD. It's quite complex to describe that, but in a nutshell, that's how it is really. And again, it's something that if anyone's got a question at the end, we can try and recover as well then. So in terms of how common it is to have these different variants, so if you think about 100 people with ADPKD in a room, you're going to have 78 of them having PKD1. You're going to have 14 having PKD2, of 2 having other types of genes, so the GNAB and the IFT140s and all the other sort of smaller print genes. And then the remaining 6, we won't know. So that'll be ones that have no mutation detected. And you're probably thinking, well, why does it matter what's caused it? I've still got ADPKD. It does matter. So it can give you some certainty. So certain variants can behave differently to others. it can mean you can test for relatives. So if you've got a variant that we know about, we could look at your children or look at your parents and test them to see if they've got the same variant as well. It also can be important for certain treatments. So certain treatments like tolvaptan, if you've got a certain variant, you might be eligible for that on that one criteria. And also certain trials will require you to have a certain variant as well. So it is important to know, is it the be all and end all? It's not, but it can just give you a little bit extra more information and give you access to things you might not have known about otherwise. Oops. I think someone popped up. There we go. So I mentioned about cysts earlier. So in the kidneys, these cysts form in something called the tubule. So the tubule is this tube part that you can see on the right-hand side image. And that's part of something called a nephron. So the nephron is the bit of the kidney that does the filtering. So these cysts develop in the tubule. So that's the little bit, the sort of squiggly bit that's coming after the little, what looks like a cup at the start. And what happens is one of these variants make the cells lining the tubule grow too fast, so then they form a bulge. And then these cells then release fluid into the inside the bulge, causing a balloon, and the balloon can then increase in size, and then over time this can then separate from the tubule to form a separate cyst. And these cells can be in other places as well as the kidney, so they can be in the liver, they can be in the pancreas, and they can infect some blood vessels like the ones in the brain that cause aneurysms. So when someone comes in, it has a problem. And in terms of the symptoms and signs that people can get, so a sort of common symptom that people might present with is kidney pain, and it tends to be either back pain or flank pain that people might describe. You might get abdominal discomfort and bloating, and that could be due to the kidney size themselves as they get bigger. You can have a drop in your kidney function, and some people present like that. So with symptoms of kidney failure. You could have high blood pressure, and again, we'll touch on that later. Kidney stones, which are associated with ADPKD. You can have problems with the cysts themselves, so you could have an infection or bleeding in the cyst, and that might lead to seeing some blood that's visible in the urine, or just blood when they do a dip and they tell you, oh, you've got invisible blood. So you wouldn't see it with the naked eye, but you might see it if they do a dip. And then the final thing is urinary tract infections. Because you've got these cysts and you've got this potential kidney stones as well, you're at an increased risk of getting urinary tract infections. And in some people, that can be how it presents. People who get multiple urinary tract infections, and then it sort of leads to them having an ultrasound and then finding out about their polycystic kidney disease. And in terms of these cysts, so these cysts generally enlarge slowly and it tends to occur over decades. So if it sort of starts around 30, 40 with the cysts because starting to be a problem, it's not going to cause an issue in terms of your kidney function until a little bit later. And as these cysts get bigger, the kidney size increases, so then your kidney function then starts to gradually decline. Usually this is slow. It's uncommon for this to be rapid. If it's rapid and if things are progressing very fast, usually it's something else. So it could be something like a blockage, or it could be things like diabetes can make it go a bit faster, or other problems. It's not usually ADPKD. It's usually a bit slower than other causes. And what happens is roughly every year you have an increase in about 5% in the sort of volume of the kidney. And at a certain point, sort of the amount of volume, the amount of cysts gets too large, and then it causes the kidney function to start dropping. So before you know about, before you see that your kidney function has dropped on a blood test, your kidney size will have been increasing in the background. You're having more cysts. And that's what this graph's showing. It's showing that over time, the size of the kidney volume is steadily increasing. And for a while, the kidney function's nice and steady. Then at a certain point, it's like a tipping point. The function then starts to decline then. And on this graph, the arrow is a bit too rapid for my liking for the kidney function, but it's the best graph I could find. And there are other things that can affect the progression. So not everyone that has ADPKD will behave the same way. Their function might not progress the same way. And this can be due to different genetic causes. So certain variants can progress a lot faster than others. So PKD1 in particular is one that's probably a more severe variant with the sort of other cysts, the other causes rather, being the ones that are sort of less severe generally. But there's no sort of right or wrong for this. It's sort of just a general pattern. It doesn't mean someone that's got PKD1 will always be more severe. It doesn't mean that someone that's got one of these other causes might not be severe. It's just a pattern that we've observed. You can also get other genetic risks. So every time your genes get copied between parents and passed down, you can have other things that can affect your risk of general health, and that could affect your kidney function as well. You can have other kidney diseases on top. So I mentioned diabetes, high blood pressure, they can also cause kidney problems. If you have them on top of ADPKD, it might cause other issues. In terms of complications, I mentioned things like cyst infections. They can make you unwell and drop your function faster than it would do otherwise. If you've got other medical problems, they can also affect the kidney function. Have you raised your hand, Susan?
Yes, it just seems the perfect time to interrupt, and it's not like me when someone's speaking. Robert's asked a live question there into the chat there. And does ADPKD tend to follow similar progression to family members? If you've got a family history, can you expect the disease to progress at a similar rate throughout the family?
Yes. So it's not an exact science, but if you have a family member that say reaches end stage kidney disease or kidney failure at a certain age, it might be that other members of the family follow suit. These other sort of things that can affect progression would also affect when you'd reach that point as well. But as a general rule, it gives you an idea of when you might come into problems as well. So if you know that I don't know, so you're someone that's recently been diagnosed and you've got a parent that's also got ADPKD and they've had a transplant at say age 50, 60s, it might be that you'll end up the same way unless something different happens. So if you have certain medications like tolvaptan, that might push that a bit into the future. Or if you sort of know about it earlier and keep on top of things, you might end up with a different trajectory. If everything's exactly the same, you'll roughly be around the same sort of timings in terms of progression. But like I said, medicine's not an exact science. It's not going to be to the year, it's not going to be to the day. It's a rough idea of how things might present.
Thank you.
That's all right. And then the other sort of things that can affect it. So I was just mentioning about sort of changing things in your lifestyle. So things like smoking that can progress things faster. If you're a drink to excess or you're overweight, all these things can just affect your general health, not specific to your ADPKD, but they can make your overall health worse than it would have been otherwise, and sort of bring things like transplant, dialysis, kidney failure a bit closer than it would be otherwise. And then someone asked about monitoring. So they asked, is monitoring creatinine levels sufficient to properly assess PKD stage and progression? So if you remember me talking before about the kidney function dropping later than the increase in size, it means that there might be a while where your creatinine and your EGFR are nice and steady as they go along, and we wouldn't necessarily know something's going on in the background. So the way to sort of know if things are changing in terms of the cysts and in terms of the kidney size is to do an ultrasound. So at Sheffield, and I think it's the same in most places, most people have a regular follow-up appointment with their nephrologist or with the specialist nurse. Most of the time, this is once a year. If it's a bit sooner than that, it might be that they're wanting to keep a bit of a closer eye on you. But once a year, you'd have an appointment. They would do your blood tests, so they'd tell you what the EGFR and the creatinine is, which we'll go on to on the next slide. They'll do your blood pressure and they'll check your urine to see if there's any blood in the urine. Sometimes we check for protein as well, and that can influence what sort of medications you might have. And in terms of keeping an eye on the cyst size, the kidney size, and the number of cysts, they'll do an ultrasound roughly every 2, 3 years is what we do at Sheffield. People do it different in different places. We like to keep maybe a close eye on what's happening in terms of the kidney size. Not everywhere does the same, and it is kind of dependent on what your function is doing as well. Again, this is specific to Sheffield. We like to do an MRI so that's a more detailed type of scan to look at the kidneys to try and work out your kidney volume. So that between the two kidneys, if you put them together, how much volume would there be? And that's because it can give you an idea as well about how things might progress in the future, and also can mean you're eligible for certain medications like tolvaptan as well. And that would usually be once, unless there's some other reason for us to think, oh, things are changing. So if someone's increasing their pain or they got more abdominal distension, we might do an ultrasound outside of those times or an extra MRI outside of those times as well. So again, not a hard and fast rule, but they're the sort of things that you'd expect and things that we would do to monitor the condition. And I mentioned about creatinine and EGFR. So someone asked specifically this, could you explain the creatinine levels in EGFR as I don't understand and no one's ever explained? So the best way to think about it is in your body, all the cells are producing waste constantly. And creatinine is a waste product that's produced by every single cell in your body. And the kidney's job is to get rid of this creatinine. So if your kidneys are working perfectly, really healthy, nearly 100% of that creatinine would be cleared. So that would all go into the urine and then your body would get rid of it. If your kidney function starts to drop, that creatinine isn't all fully cleared. So you might get a little smaller amount of that creatinine getting rid of. So some of that creatinine stays in the body. So when they say they're looking at things like your creatinine levels, that's what they're looking at. There's a set range depending on things like your age, sex, and ethnicity as to what a normal amount of creatinine would be. And that kind of brings me on to EGFR. So EGFR stands for estimated glomerular filtration rate. So sometimes people describe this as a percentage. So someone might say you've got, I don't know, 80% kidney function. And it's closely related to percentage, but not quite. So if you have perfectly working kidneys, then above 90 would be the number. So the tests that we do don't go into more depth than that. It will just say above 90. And what happens is it's not measuring exactly how your kidney function's working, it's measuring the amount of creatinine that your body's getting rid of in a minute. So it's trying to work out in a minute how much of your blood is being filtered. And the way it does that is by looking at how much creatinine was in your body and how much creatinine is out afterwards. So by a maths is how they work it out, really. It's not a real number. It's a number that's sort of worked out based on the creatinine level. So the two things are linked. So when you're thinking about one, you could have to think about the other. So the way that it works is if your kidney function is going down, they mean your EGFR is going down. So it'd be going from 90 to say 80 to 70. The flip side is happening with the creatinine. So as the EGFR goes down, the creatinine number goes up. And they just they mirror each other, but they're the opposites. And when we sort of think about the kidneys themselves, so I mentioned about the nephron. So again, it's there on the right-hand side. When you're born with between 1.5 million of these nephrons per kidney. And as what happens as we get older, or we have different problems. So if you have a kidney problem for another reason, or you have high blood pressure or diabetes, or in this case, in polycystic disease, you have the cysts that are compressing the good parts of the kidney that are working healthy, then this number goes down over time. And a lot of the time, this damage is permanent. If you catch something early, so say if you had a urine infection, you get an antibiotic and it treats it, that you might get a bounce back in some of the numbers. But if it's something that's for a longer period of time or something that's more severe, these nephrons don't work anymore. And it's not like the liver where people know it can regenerate itself. In the kidney, it can't regenerate itself. Once these nephrons are gone, they're gone. And when we sort of think about CKD stages, it's because more of these nephrons are sort of being lost along the way and it puts you into different categories. So some people ask about CKD stages and people might say you're stage 1, 2, 3A, all the different numbers from 1 to 5. And it's based on what your EGFR is doing at the time. So I mentioned about 90. So if it's more than or equal to 90, it'd be called normal, essentially. And then as it drops down over time, you reach a different category. And largely these categories don't make much of a difference. They probably mean more to sort of other types of doctors. So kidney doctors, we just look at the numbers. We don't really focus on the stages quite so much. We're sort of more looking at what the trend is in the numbers and what's happening over time. But this is what these numbers mean. So as you sort of go down, you can see the EGFR numbers going down and it's progressing into different stages. So 1 to 5. So, and the reason that it's sort of hashed on the stage 1 is that some people will have 90, some people will have higher than 90, they might have over 100. But the test that we do only says more than 90. It doesn't go into the details of 101 or 103 or anything like that, just more than 90. And when I sort of think about EGFR, I think about magic numbers. So there's certain numbers that stick out in my head as a kidney doctor. And generally it means that we have to try and have a think about something at a certain time. So when people drop down to an EGFR of 15 to 20, that's when I'm thinking in my head, oh, right, we need to make sure we've talked about kidney replacement therapy. So that's things like the dialysis, about transplant or conservative. And when it's less than 15, so you have to 15 to 20 is when you're thinking about it. Less than 15 is when you have to make a bit more of a firm decision. So that for preemptive transplant, so if you're getting a transplant from a relative, like a living donor, wait until under 15 is what happens in a lot of cases, and they'll wait for 2 results that are less than 15. And the same for things like dialysis, they'll be thinking about it at 15 to 20, less than 15, people might start asking you to sort of make a more of a decision about it. And that's not because you're going to start immediately at 15. The average start on dialysis in the UK is between an eGFR of 6 and 8. So you still have got time. It's just they're wanting to make a plan. And the reason we want you to make a plan is because otherwise the sort of decision gets taken away a little bit. You sort of get the default, which is a line and hemodialysis. So things like peritoneal dialysis or dialysis with a fistula sort of it's tricky and takes time to sort. So the sort of sooner you make a decision when you're around these sort of numbers, the better, really. So that's the sort of quick whistle-stop tour overview of the condition itself, how it progresses, and how we monitor it. The next bit's about your family and why having this condition matters to the family and how to discuss it with the family as well. So I mentioned it follows an autosomal dominant pattern. So that means that there's a 50% chance of passing on the gene variant, and each child of an affected parent has a 50% chance of inheriting the condition. And this is because you only need one faulty gene to cause the disease. You can be the first in your family, or you can have a long line of family members that have also been affected. But importantly, it can't skip generations. So if you've got it, it either means you're the first person in the family to develop it, so it's something they call de novo, so it's all of a sudden it's new, and in Latin it just means new, or you've got family members that have had it. So it would mean that either your mum or your dad would have had the condition. They might not know about it, so sometimes if you've got a more mild variant, then they might not know about it because they might not have ever had a scan, and it might not have ever caused them a problem. It could be that something else happened. So if someone got a different type of condition and that's what led to their death before they found out about it, that could also mean it looks like it's skipping generations, but it can't. So the condition means it can't skip generations. It has to be passed down through the generations. And like I said, so dominant means that you only need one copy to develop the condition. So on this diagram, this is two parents. So you've got a parent on the left, a parent on the right, and you've got their genes. So these are the chromosomes. So this when we sort of talk about this, each parent passes on one of their chromosomes. So the person on the left on this side, they've got a little green line, and for all intents and purposes, that is the gene that's causing ADPKD. So the person on the right has got two copies that aren't faulty. The person on the left has got one faulty copy and one non-faulty copy. So that means that there's four different combinations that you can have. So you can have two of the people can have inherited that faulty copy because it has to be passed down like that. So it means every time this couple would have a child, there'd be 50% chance of inheriting the faulty gene. So that resets every time. So each time they have a child, it's 50%. So it's the same as flipping a coin. So if you're trying to get heads on flipping a coin, you'd be flipping a coin every time you had a child. So it could be that some people end up with having no children that have ADPKD. It could be that people have all the children have ADPKD because it's chance. It's not related. They sort of don't depend on what happened previously for that exact new child that's been developed. And sometimes you might see that it just expresses a diagram like this. So when you come to a genetics clinic, it tends to be they might draw a diagram like this, and it's called a pedigree, and it's showing what your family tree is like. So the circles that are on there are females, and the squares are males, and the ones that are coloured in are people affected by the condition. So on this, you can see it's not skipping generations. There's at least one person in each of these lines going across that's got the condition, and that's because it's autosomal dominant. So just to reiterate, it can't skip generations. And it could be, like I said, you're the first person. So you could have had a variant that's just happened just for you and not affected anyone else. You then could pass it on to your children, but it might mean you have a family tree that looks like this, where no one else is affected. And the flip side of that is, like I said, if you've got particularly a more sort of mild variant, it might be that no one in the family knew about the condition. It might be that other things have happened in sort of ahead of the polycystic disease becoming a problem. And testing in family members. So someone said they had two children, they had both sons. Is there an optimal age for them to be checked to see if they're ADPKD? I think it's important first to think about how we test people for ADPKD. And there's two main options. It can be done through imaging or it can be done by genetic testing. So the imaging that generally happens is that people have an ultrasound, and I'll get onto that about when people have that sort of timing, or if they have a genetic test based on your genetic test. Usually it would be that the person that's got ADPKD, and we know that from the fact that they've got the number of cysts on the images and they're confirmed based on imaging, they would have a genetic test, and then we could test their children. If someone's a child, or and I say a child, it could be someone that's older than sort of children age, if they're in the sort of teens, 20s, 30s, and they've got no symptoms of ADPKD, it's very tricky for us to test those people. It's usually easier to if we have a known variant and then we test them for that specific variant. So if testing them out the blue, there's so many different genes that could cause the issue that it's not that accurate to be able to do that. It's better to know a variant that someone else has in the family and then test them for that variant. And the sort of timing of this depends really. There's no exact guidance that says you have to do it by this age, you have to do it in this situation. It's all personalized to the person and their children. So it could be dependent on their age. Some people wait till they're a bit older, so they're involved in decision making. It could be that some people aren't ready and want to delay things. There's no exact science, no exact rules about how it should be done for anyone. And there's benefits and limitations for both of them. So some benefits might be that it gives you some certainty. So the child might know that they've got the condition ahead of time, and it might mean you can do some things earlier, like keep control of people's blood pressure, or it might have an impact on how people make their family in terms of like family planning decisions. But there could be limitations. So it might impact things like work. So certain employers, so it tends to be in things like the army, they might not allow you to do all the roles that you might want to have done. It could be that it affects insurance, and we'll touch on both of those later on. So I mentioned about imaging. So ultrasound is the most common first step for any screening with imaging. And this is because it's non-invasive, it's very quick to get, and doesn't involve any sort of radiation or anything. It's not that accurate in young children. So most cysts happen around sort of 30 to 40s when people start developing cysts. Some children do have them, and you can see them on ultrasound when sort of in the womb, but that's not that common. So what happens is that if you think someone might have ADPKD and you do a scan and there's no cysts, until they're the age of 40, you can't rule out the condition. So if you've got a child that's say 26 and they have a scan and it says no cysts are there at all, that just means that there's no cysts there at the moment. So it could be that they have got the condition and they develop cysts later, or it could be that they don't have the condition and they will never develop cysts. So what I have to do in those cases is keep repeating that scan until the age of 40 to be able to say, right, if you're over 40 and you've got no cysts, it's very unlikely that you have ADPKD. So that involves people seeing their GP or seeing their nephrologist a lot more often than they would do otherwise. The flip side of that is genetics. So I mentioned if you have a variant that's known, that's how this can work. If you have your genetic testing and they don't find a variant, so no mutation detectors as it comes back, they can't do genetic testing in family members because they will also come back the same and say no mutation detected. So it's only useful if you have a known genetic variant. And the benefits of this is that it can detect preclinical disease. So you'll be able to know if you have the condition before you even start developing cysts. And sort of implications for that is that it means you can have earlier treatments. It means that we can keep a closer eye on things. But like I said before, things like insurance and employment might be affected. And my sort of practice is that I generally say to parents to wait till the children are a little bit older to understand. It's a difficult thing, I think, to understand, and so the sort of movement of the sort of communities towards giving children a bit more engagement in their decision making rather than making the decision for them. But again, there's no exact science, no exact rules on when you should do it, how you should do it. It's dependent on that specific family a lot of the time. And in terms of family planning, so there's a good video from Dr. Kate Branham and one of the renal midwives, Catherine Clark. So I've put the QR code for that at the bottom. But there's four main options. So the first option is you have natural conception and you have the 50-50 chance of your children inheriting the condition. The next ones are where you're sort of doing something different to try and reduce the risk. So the second one is IVF with pre-implantation genetic diagnosis. So that's where they do IVF, where they take the egg out, take the sperm out, and then they put them together. They allow them to grow into an embryo, take one of the cells, do a biopsy, so to put a little cut in it, take out some of the genetics, and then they look at those genetics and say, has this embryo, so has this collection of cells got the genetic problem? Has this inherited the faulty gene? And if the answer is yes, then usually what would happen is that wouldn't progress to become a baby. They wouldn't sort of reimplant that. And then they do that with a selection of ones that they've done and then implant one that doesn't. So that is almost 100% going to be that you can't pass on the condition. Some people use donor sperm and eggs, and again, that's another option that can be with IVF, or it can be sort of natural conception, and then finally adoption. So natural conception, you will have that 50-50 chance, and everything else is going to be a lot less than that. That's probably the best way to describe it in a nutshell. I won't sort of linger on that point. Oops, I think someone come in. And so when I said about IVF, this is the sort of process that people would go along. So it is just having an egg that's separate from the body, and then putting a sperm in with a needle, embryo developing, doing a biopsy, having a look at the genetics, and then putting it back into the woman into the as an embryo to transfer it into the womb, and then allowing it to progress as a natural pregnancy. So that a whistle stop tour for why sort of being it might matter for families and also family planning. So the next thing we're going to talk about is how it will be treated. So I've broken it down into different sections, and I'm happy to answer questions about these at the end because I think this is generally where people have a lot of questions. So the first thing is general health. So these are sort of things I tell any patient. These are not specific to ADPKD patients. So if people are smoking, we generally advise to stop smoking because it increases the risk of heart attacks and strokes, and it also can cause furring of your arteries, which can damage the kidneys as well. Being overweight can also cause cholesterol to build up, which can cause the narrowing of the arteries and also lead to problems with the kidneys. Generally say to people to do exercise. There's a caveat for people that've got ADPKD. Generally say to avoid any sort of high contact sports, so things like rugby, just because there's a risk of hurting them, your kidneys, and popping a cyst, which can be painful. And actually, that can be a way that some people are sort of diagnosed incidentally. There might be some people on the call that were found out they had it through this. I definitely know patients that have myself. I and for most of the time, there's no sort of prescriptive diet. It's just generally a well-balanced diet that I'd be advising with low sodium. So not avoiding salt in the diet. And it's mainly because of the effect on the blood pressure. So if your blood pressure is high, it's a problem that you can control a little bit. And one of the other slides will talk about blood pressure. But having a high blood pressure, even a small amount over a long period of time, can cause damage to the kidneys. And it's something that you can control. Generally say to avoid lots of caffeine and to stay hydrated. So becoming dehydrated is generally not good for the kidneys. They don't like to be dry. In terms of pain relief, so when people have got cyst pain or they've got pain related to the actual volume of the kidney, it can be tricky to manage. So, some of that's fine. It can be tricky to manage. Oh, so I'll just see if there's any reverb. It seems fine. So usually we use simple painkillers for cyst-related pain. So that's things like paracetamol to start. Paracetamol on its own is some people don't view it as a very good painkiller. It's good with other things. So if you're taking paracetamol regular, that get on top of things a lot better. If you take a paracetamol here and then, it's generally not as good. But obviously, I wouldn't advise you to take any more than the sort of recommended dose, but to the maximum of the dose, you could increase it to that, and it is generally a better pain just to keep things at bay. You can then add in other things. So we generally say to avoid things like ibuprofen or Nurofen, just because of the way that they interact with the kidneys, they can cause damage to the kidneys. So I tell all my patients just to avoid it. It's just not worth the hassle of trying it really. It's annoying because it's a good pain killer, but it's one that can have problems with the kidneys, and you won't thank me later on. So alternatives, so we sometimes give people things like codeine and an oxycodone, morphine if it's really severe pain. That when it's that type of pain, there is, and you're giving that type of painkillers, the risk of constipation, which can make things worse. So I generally give people a laxative at the same time. Other things, so we can give people patches for pain, and there's some sort of pain that works more on the nerves, which is gabapentin and pregabalin. And if none of this is working, we can try other things. So some people find acupuncture helps. Some people find the TEMS machine, so it's where it's giving electrical pulses that can help. And I sometimes refer patients to pain specialists. So these are types of doctors and nurses that work in the hospital that are specifically trained in how to manage pain. And some people get pain when they've got ADPKD, some people don't. There's not a sort of pattern as who gets it and who doesn't. A general rule of thumb is if you've got bigger kidneys, you're more likely to get pain, but it's not always as sort of clear cut as that. Some people can have very big kidneys and have no pain at all. Some people have smaller kidneys and get lots of pain. It's very personal to the individual. It's not specific based on the size or anything like that. And I mentioned about blood pressure control. So this is a rule of thumb. This is a target that we aim for. So it's less than 130/85. In some people, we might aim for a bit lower than that. Some people might aim for a bit higher than that. So if you're someone that is a bit older, and you have problems sort of when you stand up about feeling dizzy, we might say, oh, we don't want you to go as low as that. If you're someone that's younger, we might sort of push things a bit further and try and get less than 120 for the top number. And usually we sort of say to do the lifestyle changes we mentioned first, so things like exercise, healthy diet, avoiding salt, and that can try and push someone underneath that target. It might be that some people need to have blood pressure medication, so antihypertensives, to try and bring the blood pressure down itself. So the first line pretty much everyone's going to say is ACE inhibitors or ARBs. So these are things like ramipril or candesartan. And the reason they're first line is because they've got extra benefits. So both of those type of medications not only reduce your blood pressure, they slow the risk of your kidneys failing over time. So they might slow things down a little bit or reduce the risk. They can also reduce your risk of heart attacks and stroke. So it's a tablet that's got multi-uses, so it tends to be one of the first ones that we go for. There's some evidence that controlling blood pressure can slow kidney cyst growth as well. It's not definitive, but there are some studies saying that that might be possible. And like I mentioned, reducing your blood pressure with the tablets or otherwise helps reduce your cardiovascular risk. So it helps reduce the risk of you having heart attacks and strokes, and also might push things like kidney failure a bit further into the future and push dialysis into the future, push transplant into the future. In terms of managing complications, so if you have a urinary infection, it's really important to get that treated early. There's a risk that that can progress quicker than it would do in someone else. And it could be that it's a cyst infection. So when people have a cyst infection, they tend to be a bit more sick than people would be usually with just a normal urinary tract infection. So in those cases, it's important to see the GP or even an A&E if it's that bad early, because you don't want it to progress quickly. Other things, so I mentioned about kidney stones, it's important that that's kept an eye on. So doing the ultrasound, that can tell us if you've got kidney stones, and then there's different treatments for that. One of the best things to do to try and reduce the risk of kidney stones is to just drink plenty. So the reason kidney stones can occur is if you've got lots of calcium in the urine. If your urine's concentrated, there's lots of that calcium together and then it can clump together and form a stone. Whereas if you're drinking plenty, it doesn't have a chance to do that. It's like squash, you diluted it down so much that it can't clump together and form a stone. So the best advice for kidney stones is just to drink plenty. Some people also get liver cyst symptoms. So liver cysts, some people get lots of liver cysts, some people don't get very many liver cysts. There's some evidence to say that females get more liver cysts because it's hormone related, and that having estrogen is what drives liver cyst development. Causes largely similar symptoms, but you don't get the impact on liver function. So if you have an abnormal liver function test when they do a blood test, that's not because of ADPKD, that's more likely due to something else. It's not like the kidney where it affects the way that the liver's functioning. It doesn't affect the way the liver's functioning. People ask about tolvaptan, and that's what my research is on. So I'll talk about that very briefly. So someone asked, they've been diagnosed recently and want to know how they can be prescribed tolvaptan. So I've taken the guidance that doctors in the UK use for eligibility for tolvaptan. I've put that on the next few slides. And this is guidance that was released last year. So I was one of the authors on it. So the criteria, so you have to have a confirmed diagnosis of ADPKD. So that could be via imaging or that could be via the genetic testing. At the moment, you have to be 18 years or older. So there are some trials going into younger people, but they haven't got large enough numbers for us to reliably say whether they make a difference or not. And in England and Wales, you have to have the CKD stage 2 or 3, and then in Scotland it can be 1 to 3, and that's to do with the way that the medication's licensed. It's England and Wales has got a different regulatory board to Scotland in terms of who decides who can have these medications and how they're funded. And to be eligible, so we say it can be based on your eGFR slope, so the amount that your kidney function is going down every year. So we can look at that, and if it's more than 3 per year for 4 years, then we could prescribe it based on that criteria. It could be that we do it based on your kidney length. So if you've got a kidney size on an ultrasound which is bigger than this number, 16.5, you might be eligible. Again, next ones, you sort of total kidney volume. So if they do the MRI and look at this, how much volume of kidney is together, more than 750, then that could be an indication. And the last two are more sort of bringing some of these other bits in together. So the Mayo imaging class, so that's where they look at the size of your total kidney volume and compare it to other people that are the same size as you. And what they do is risk stratify you. So they say people that are in 1A and 1B, you're slowly progressing. You're not likely to progress very fast. You're not someone that we're particularly concerned about. If you're in the classes 1C to E, then they are a bit more concerned, and that could be an indication to have tolvaptan. And then the final one is something called pro-PKD, which brings in some of these things together. So it brings in your genetic diagnosis, and it brings together sort of clinical findings like what age you had urinary tract infections and urinary symptoms, that type of thing. So, and what they do is they put all your criteria, all your information into a score or into a calculator. And if the score is more than 6 or equal to 6, then that would be an eligible reason for tolvaptan as well. And you can see this age brackets on some of them, and that's because these are all based on trials and sort of studies have looked at this to see what age groups benefit from different things. So again, it's difficult to give anyone like a specific you are eligible or not without knowing the full history, but this is what people would be using to try and work out whether you're eligible or not. And I think the best thing to do is to speak to the doctor or the nurse that's looking after you and just mention tolvaptan. Everyone's human. It's probably good to remind people as well. So people will have this in their mind, but if it's a busy clinic, it's probably good to sort of take action and sort of you can mention it yourself. There's no reason you can't mention it if it's something that you're interested in. And in terms of sort of what symptoms people get, so polyuria is one of the main symptoms. So that just means going to the toilet a lot, and that the amount of urine that people pass varies considerably. Some people will pass a normal amount of urine, so what they did before they were on tolvaptan, and some people will pass up to 8 liters. And this is people describe it as a side effect. It's not really a side effect. It's how tolvaptan works. So the way that this medication works is those cells that were sort of lining the inside of the tubule and inside the cysts. It tells the cells stop secreting fluid, stop putting fluid into the cysts. So that fluid has to go somewhere. So that fluid is what's being passed out as urine. So that's why the amount of urine increases because we're saying to those cells, don't put any fluid into the cysts. So that fluid has to go elsewhere and it goes into the urine. That's the way that it works. People get polydipsia. So that polydipsia just means you're thirsty. So you need to drink a lot. And that's just a sort of response to passing lots of urine that your body needs to keep up by drinking plenty of fluid. And again, like I said, some people don't have any problems with this. Some people can find this really difficult. It can be that you have problems with needing to drink and pass urine throughout the day. It can affect some people at night time. So it's definitely something to talk about if you're sort of thinking about tolvaptan, something to keep in mind because it can be difficult with some people's jobs. The other thing, and that's kind of what has an impact on monitoring, is the risk of liver injury. So one of the trials found that a very small number of patients taking tolvaptan had problems with the liver, or the way the liver was functioning. And this isn't related to ADPKD, it's the tablet that was causing this. But this isn't something that has been seen lots in clinical practice. It's something that was mainly found in the trials. Because it was found in the trials, it means that you have to have more regular monitoring than you would do for other medications. So it means you have to, for the first 18 months, have monthly monitoring appointments. So you'd have to have a blood test and speak to a doctor or a nurse once a month. And that would be for the first 18 months. And after that, it'd be once every 3 months. And it'd be like once every 3 months for the rest of the time that you're on the medication. And Professor Danny Gale's given a talk specifically on tolvaptan, so he'll cover more about that aspect. And again, I've put the QR code. And someone asked, when I asked my tolvaptan consultant, she seemed to think it was for younger, new diagnosed patients. I can understand why people might say this. So there's two different ways you can look at it. So younger people might benefit the most because you've got more to gain. So for every 4 years you're on tolvaptan, it might be that you gain an extra year away from sort of pushing it by you things like dialysis and transplant a year into the future. And again, so if you run it for 8 years, it might be 2 years. And if you run it for 12 years, it might be 3 years. So that's the kind of benefit that people get. And so if you're younger, you probably have more to gain if you run it for a long period of time. Sometimes it can be useful for people that are older. So if you're someone that's older and your function is dropping, and tolvaptan might mean that you don't ever need dialysis or transplant, it might just push that so much into the future that it doesn't become an issue anymore for you. So it's a tricky thing, and it's not something that's again not an exact science. It's probably the best thing to do is to speak to the doctor that's looking after you or the nurse that's looking after you about whether tolvaptan works for you. Again, it's sort of you have to bear in mind the sort of way that the medication works and whether that's going to be compatible with your life as well. And I think that's something that I think I would advise people to have a think about. Moving on to things like surgery. So there's not that many surgical options, so you can't go in and sort of remove all of the cysts and leave the kidney itself okay. But we can do some things. So if you had lots of pain that was related to a single like dominant cyst or a few cysts that were causing the bother, and it tends to be cysts that are at the top of the kidney because they might rub on the diaphragm, which is part of the way that your body breathes. So if people take a deep breath in, it's the diaphragm that's doing that. It's being flattened, and it might rub against the top of a cyst on the upper bit of the kidney. It might be that they could ask a radiologist to use a needle, an ultrasound, or a needle and a different type of imaging to try and pop that cyst. That can be helpful for some people, but those cysts can fill back up. And some people think that if unless there's a really issue problems causing cysts, that might not actually be the right thing to do. Some people can have this sort of cyst they call like defenestration or deroofing, where you sort of go in surgically and sort of hollow out that cyst. That means that cyst isn't going to come back, but you still will have other cysts that could just take the place of that cyst. So again, it's not a permanent fix, it's not a cure for the problem. It just might sort that problem for a little bit of time. And then very rare cases, we do nephrectomy. So if some people have got pain that's not being treated very well at all, we can remove the kidneys or one or both, depending on if one's the issue or both the problem. You've got to think about the consequences of that, because if someone comes and removes the kidneys, you haven't got any kidneys. You then need to have dialysis or a transplant. And sometimes they might do that preemptively for a transplant. If you had particularly large kidneys, they might say, oh, there's not enough space for a transplant and might need to remove a kidney before that. But it's not that common that we do that in the UK. But again, if pain's a real issue in the future, that might be something that you could talk to the doctor about. And then sort of moving on to sort of when you reach in that end stage, so when you're less than 15 and you're trying to think about the different options are covered by one of them, transplants covered by Mr. Hussein. So again, on that QR code. But when you get to that point, you've got to think, do you want to do hemodialysis? So that's blood dialysis, where they take the blood out and the machine spins it around, filters it and cleans it, and then pumps it back into you. And that can be done in a hospital or that can be done at home. Or do you want to do peritoneal dialysis? So that's where you have a tube put into your stomach and then a bag of fluid in a machine or just with gravity. And what happens is that fluid goes into your in lining inside your abdomen, and then fluid by osmosis, so people probably remember that from biology class, goes across and it gets rid of these chemicals, and then the fluid all gets sucked back out, and you have to repeat that on a sort of daily basis. And that can be done at home, or you could have transplant. And there's different types of transplant. I mentioned living donor, so that's from a relative. It can be a relative or someone that's unrelated, that could be giving you a living donor transplant, and that's from a living person that's having been operated on at the time, or it can be from other people. So it can be when people have had an accident and their brain's not working, but their heart's pumping well. So that's this DBD. You might hear the abbreviation, or it can be after people have maybe had a heart attack or something. And that's the DCD, so cardiac death is what. So brain death and cardiac death. So there's different types of transplant. And again, these are sort of things that are in the future, not something I'd necessarily be thinking about all the time, but these are things to have in the back of your head for when someone mentions them. And there are some new trials. So there's two trials that I'm aware of that are already recruiting at the moment, another two that are ongoing, sort of in this early stages. Some of these trials are repurposing medications, so they're taking medications that have been useful for other diseases, so things like diabetes, and seeing do they have a benefit for ADPKD. So two of these are one's metformin, so it's a diabetic medication, an SGLT2 inhibitor, which is another diabetic medication. So they're trying to see, we know these work very well with people that have got diabetes. Will they do anything for ADPKD? There's another trial that was looking at whether the amount of fluid you drink makes a difference or not. And then new medications are coming through with some early trials as well. And there's a Sheffield's recruiting to a trial at the moment. So there are things on the horizon. There's probably more than there has ever been really that's coming through at the moment. So it's a good time to sort of be thinking about these extra things. Whereas if you were back in the 80s, back in the 70s, they barely knew about it. They only just found the different genetic causes. So I'd watch this space and I'd mentioned to your doctors or to your nurses that you're interested in trials because they will be recruiting for trials. Then finally, just moving on to sort of what about your sort of day-to-day life? So what's the impact on work? So there is no law saying that you need to inform your employer, but you might want to inform your employer. So things that they can help with. So if you were someone that was on tolvaptan, for example, that's a common one that I get asked to write a letter for. They might write a letter saying that they be closer to a toilet, or you might need to go to appointments for pain, or you might need to be admitted for other medical problems. So it can be helpful to tell them, but they can't ask you, and you don't need to tell them. You are protected under the Equality Act of 2010, so that is something to be aware of. Doing a quick Google search will find out what that entitles you to, but they can't discriminate against you because of a disability. And in this case, having a condition like ADPKD is classed as a disability. I think the best thing to do is if you're concerned about work or you're having difficulties at work, I regularly write letters for patients to say this is what ADPKD is. These are the sort of adaptations I would think would be reasonable for an employer to make. Obviously, some jobs that's not going to be possible, but most jobs they can make adjustments to. In terms of things like mental well-being, we know that anxiety and depression can be higher in people that have got chronic kidney diseases in general, can be higher in people that have got genetic conditions. So it's important to be aware of this and to be aware that no man's an island. It's important to discuss this with your loved ones, discuss condition with other people. Some people find it helpful talking to other patients, some people don't. And genetic guilt is a real thing. Some people really worry about the fact that their relatives have also got the condition. And it's not anyone's fault. It's not your fault. It's no one's fault. But again, this can be something that I think is important to talk about. Suffering in silence with these things isn't really an option for me. Moving on to insurance. So when you're applying for life insurance, you can be asked about any diagnosed health condition. So they could ask you, do you have ADPKD? They could ask if you have a family history of inherited conditions. So if you knew that your parent had ADPKD, but you'd never been tested, they might ask you if you've got any inherited conditions. They might ask your current kidney function, and they might ask you for any treatments you've had or you're having. And this can affect your insurance. It doesn't mean you can't get life insurance. It just means that you might have to pay a higher premium, or you might have to use a specialist broker to get the insurance. So it doesn't mean you're not going to get it. So you can't be denied based on having ADPKD. It's just exclusions might happen, high premium and broker. And they will not ask for the results of a predictive genetic test. So predictive genetic test is in someone that's got no symptoms. So I said we very rarely do this. So if you're someone that's got a relative that's got ADPKD and we're testing you, that would be called predictive. We don't know, we don't have a reason to suspect you have ADPKD other than your family history. If you're someone that's got symptoms, that's not a predictive test. That's a normal genetic test. So they can't ask you for the results of a predictive test. So if you have no symptoms, they can't ask you for the results of that. What you might want to tell them if you had ADPKD in the family, and then if you have a negative test, because that would mean you don't have ADPKD. So it's a tricky thing to sort of get your head around. The PKD website's got a really good page on this, and this is where this information's from about the insurance and the impact. It's not easy to sort of explain and not easy to sort of get the point across about it. Importantly, for things like a mortgage, shouldn't be affected because it's more about how you're able to repay the mortgage and repay the loan and your credit card history. It shouldn't be affected by any medical conditions. And then finally, moving on to things like driving. So if you drive a car or a motorbike, you don't need to inform the DVLA unless you've got some very specific things. So that would be if you've got an aneurysm. So that ICA stands for intracranial aneurysm. So if one of the blood vessels in your brain has formed an aneurysm where it forms like an outpouching, which can be associated with ADPKD, or if you've got really high blood pressure that's not controlled at all. In those situations, you need to tell the DVLA because you're at a higher risk when driving, or there's a chance that something might happen. If you drive a bus or a lorry, you do need to tell the DVLA. It doesn't mean that you can't drive a bus or a lorry. You just have to inform them of the fact. I think I've talked for a long time. For a long time, I'm not sure what time it is. But so we've sort of covered a few different things. So we covered what is ADPKD, we've covered what about your family, how the condition will be treated, and what about your day-to-day life. So this is just going back to the contents at the start of the page. Everyone's probably sick of hearing me talk.
No, Matt, that was amazing and very, very informative. I have to do say that I didn't do a 15-minute warning or a 5 minutes. We've now reached our full hour, but that was absolutely amazing, and I do appreciate the time and the preparation that's went into that presentation. It was absolutely fantastic. Now, we did say we would keep you till past. I
I'm
hope you
happy.
don't have a hot date, can you? And I'm going to say, if we say perhaps 10 minutes, there is some questions come in, and I know
Sure.
there was another couple that came in advance at a late stage. So is it okay with you to proceed? And I'm going to say 10 minutes. So we will close at 22.
That's fine for me.
Perfect. The first question that I caught my eye was Louise, who's newly diagnosed. And should she get her pharmacist or pain management team to rethink her current medication? She goes on to list and name two medications she takes. One's gabapentin for nerve damage, and the other one's northriptyline or similar. I do apologise for my pronunciation. But we did cover some pain medication, but it's
Yeah.
always wise to.
So those two painkillers are really good painkillers. Like you said, they're more to do with like nerve type pain. The downsides of those type of painkillers is that they can make you drowsy. So that's why we tend not to use them all the time. You could keep taking those medications, and you can always have paracetamol on top if the pain's a problem. It depends what they were started for. If they were started for ADPKD, it'd be unusual to sort of go in straight away with that. We sort of describe things as like a pain ladder. So when you're at medical school and when you sort of training to be a doctor and all those sort of things, they talk about a pain ladder. So, and the reason is that is you're sort of going up different rungs. So the sort of ones that you're on there are kind of at the top of the rung. We wouldn't usually sort of climb a ladder by starting at the top. We'd usually start at the bottom and then work our way up. So it depends if they've been started for other reasons. They might be beneficial for ADPKD. So if you've got nerve damage for another reason, they'll treat the same, they'll treat both types of pain. It's just it wouldn't be one that I'd sort of immediately go in at. It's one that you're going to more likely get side effects like the drowsiness, even though it's a good painkiller.
And someone else has popped something into the chat about the variability in the size of her cysts. My cysts are highly variable in size, with the largest ones concentrated in my right kidney. What might be causing this? Genetics. Then goes on to say, will the other kidney effectively catch up and become just as cystic over time?
Yeah, so you can sometimes see that people don't have symmetrical sort of cyst burden. Some people might get more cysts in one and more than the other. Some of the sort of more fine print condition, like the genetic variants, can cause that, where you've got more asymmetrical cysts, or if you've got the no mutation detected on the genetics, because it's a rare one that we don't know about yet, that can also cause the asymmetry. Usually, most people will have one that's probably worse than the other in terms of their kidney size and the cyst burden, to be honest. It over time, it might be they catch up, it might be that they don't. It probably doesn't make much difference to sort of your overall trajectory, if that makes sense, if one's worse than the other. If you've got very asymmetrical, where one kidney's got next to none and the other's got a lot of cysts, that's usually called asymmetrical ADPKD, and it is one of these like rarer fine print ones. But having a bit of variation between them is probably normal.
Perfect. Audrey, do you want to take some of the questions there? I was kind of keeping an eye on what I would say the lifestyle and exercise ones there. On you go.
I was just going to say there's a question about whether a daily vitamin. So the question is to help prolong kidney function or keep your kidneys healthy. Can you take daily vitamins, magnesium, or electrolytes? Can they help or will they hinder?
So they're unlikely to hinder. There are some people talking about doing a study about taking daily vitamins to see whether they make a difference or not, but there's just no evidence to say it does or it doesn't. It, I wouldn't sort of take lots and lots and lots of different vitamins because it is unlikely to benefit, but having a good balanced diet would probably do the same as having a multivitamin, to be honest. You're probably going to get a better balance of things like carbohydrates and fats and protein by doing that rather than sort of depending on a vitamin. But it's unlikely to cause any harm. I'm not aware of any studies saying it causes problems.
It seems a perfect time to ask, what of a high protein diet? Is that okay with stage 2 kidney disease?
So in stage 2, that would be fine. We usually say to try and avoid it as you sort of towards the sort of end. So if you are towards stage 5, we generally say to avoid it, just because that's where the creatinine's coming from. And another chemical that your body produces as a waste product is called urea. And normally your kidneys get rid of this chemical as well. And it's urea that causes a problem when you get to those sort of lower stages. So the protein in your body gets broken down into creatinine, broken down into urea, and the urea can make you confused and it can make you have issues that might mean you need dialysis a bit sooner. So at stage 2, there's no sort of restriction, there's no sort of advice about amount of protein. You can have protein as you'd like, but at the lower stages, that's when we'd be more concerned about it.
And there was a very similar question came in from Robert. Now, I'm laughing. We've seen, I think we've got a few of the younger members of our community, lots, I think, coming through about exercise there as well. Or I'll fill in with one. I think there's another one that'll link in there. I think it was about hydration. Someone's asking, does it matter what type of exercise they enjoy, high intensity, like jump rope, over strength training? Is that okay?
Yeah, so that's fine. Again, it kind of depends where you're at with your condition. If you're in the sort of the early stages, it's probably fine to do most things really. I still would advise you not to do high sort of contact sports, but at the earlier stages, there's probably not really any restrictions. When you're sort of getting towards the later stages of the condition, I'd be sort of trying to avoid things like heavy lifting. So you sometimes say like even people like bending over and picking something up, they can burst a cyst. So early stages, you're happy to do either. When you're sort of in the late stages, maybe more cardio than heavy lifting.
There's a question here that I think we get asked a lot as well. Somebody's saying they really struggle to drink water. Is squash okay?
Squash is fine.
Right.
Again, I feel like it's a sort of on I keep repeating the same thing, but so squash is fine in early stages. When you get to the very late stages, squash can contain some potassium, so it can be a problem like very late on, but the rest of the time it's fine.
Now, I'm going to just say we've got 2 minutes left, so I'm going to close the chat for new questions. No more new questions will be added to the chat, please. I'm aware someone's got their hand raised, and there's another couple of questions that are fantastic in here, so just cover those. Someone who, as we hear all too often, was diagnosed 10 years ago due to family history. They only saw a consultant then and were subsequently discharged. They're now keen to be put back under the care of a consultant as against an annual review with a GP. How would you advise they would go about it?
I think they should just ask the GP. I think you just have to ask your GP and request to be referred. I think that's probably the best thing to do. For me, it's patient choice. So we have patients that in Sheffield that we probably would discharge. But if they say they don't want to be discharged, we keep hold of them and we keep seeing them. It could be that you do alternate. So you could say if they're really pushing, you could say, can I not see a nephrologist one year and the GP the next year and sort of reduce that? It's the reason that sort of people get put into the community is usually to do with the sort of clinic volumes rather than it being anything else. So they're worried about you the least if they put you into the GP practice. But I think if it was me and I was concerned and I'd like to see a nephrologist, you can always request to see a nephrologist. And I think it wouldn't be particularly nice of a nephrologist to turn around and say no without seeing you at least once. And I think nephrologists are generally quite nice.
There's one there, and I take it when someone's saying about the drugs mentioned, it would be tolvaptan and the criteria for Northern Ireland. Now, I personally am not unsure of the exact criteria. Do you know it, Matt?
Northern Ireland tends to just follow England and Wales.
Mhm.
Usually it just follows the same as England and Wales. They don't have, Northern Ireland doesn't have its own regulatory body that's published any advice on tolvaptan. And when I've looked into it, they do just follow the same as England and Wales. So they will be using the same guidelines, but under England and Wales rather than Scotland.
Audrey, do you want to pick one, just a final one from there? I know there's something that I've got in a spreadsheet that's sitting behind it, come in at a late stage as well. So do you want to just take one from the screen, please?
One that's just come through is about aneurysms, and I know my dad definitely didn't have PKD. My mum died aged 57 from a very sudden brain bleed. We don't know whether it was an unknown aneurysm, so I don't know whether mine is genetic. I have no children, but wonder if it would be beneficial to know. I am 64 with an EGFR in the 60s.
So you've got ADPKD, you've got a family history of an aneurysm. That's in a nutshell. That's yeah. So again, this practice really varies across the UK. In Sheffield, our practice is if you are someone that's got ADPKD and you've got a family history or a personal history of an aneurysm, we would keep screening you. We would keep an eye on things. So every sort of 3-5 years, we would do an MRI of your head to see what's happening with that, unless we're told otherwise by a radiologist. So I think if you're concerned about it, I think I'd mention to your nephrologist and say, I've got a family history of an aneurysm. It could be related to ADPKD, but it could not be. It's going to be very difficult for anyone to ever say it's not. And I think if it was me and I saw you, I'd be erring on the side of caution and saying, actually, the aneurysm could be related. Difficult without knowing the full history, but that's what my brain would be saying.
Aneurysm was actually on the spreadsheet. That was the question I was going to bring over. We have a lovely recording for that. So we're going to have a huge list of additional resources for those that are interested tomorrow. Now, I've had someone who has incidentally been diagnosed with PKD while they were actually undergoing potentially some treatment for cancer. And they wanted to know how the nephrology, the kidney doctors, would work with their cancer team going forward.
So usually it'll be sort of dictated by oncology. So the reason that nephrology and oncology would talk to each other is mainly because of the impact that the oncology medications could have. So lots of the chemotherapies could affect the way that the kidney works, and that's not specific to PKD, it's specific to just kidneys in general. It usually is dictated by the oncologist, so they would ask us for advice. And when people are having things like chemotherapy, if that's the sort of treatment path that you're going down, what would happen is that they would check your blood test every time you have chemotherapy, and they would be alerted to any problems that might arise. So I don't think it's specific to ADPKD. The only thing that I'd be thinking in the back of my head is that you've got a risk of developing an infected cyst. And if that happened and you had symptoms that would fit with either a urine infection or sort of an increase in cyst pain, then I'd be sort of seeking out medical attention a lot sooner than I would do otherwise. Because you need to hit you hard with the antibiotics very quick, very early, because you'd be immunosuppressed and also at a high risk of infections getting worse because of the ADPKD.
Right. Thank you so much for that. And I'm going to sneak a little one in because it has been sat in the chat there.
Sure.
That's it. No more. Promise you. I promise you.
Oh, honestly, I don't mind. I literally don't mind.
We could be here all evening. Someone, we spoke about incidental diagnosis. Someone's unfortunately had a traumatic brain injury and their PKD was discovered while they were in hospital. And PKD is progressing and getting worse. Will the two of them, the brain injury and the PKD, what do they need to be aware of moving forward between their own brain injury and a diagnosis of PKD? Is there anything that you can say, or do you think there's really speak to their medical team?
Yeah, I think they're two separate issues, to be honest. So I could talk about the PKDs, the advice that I've sort of given the whole time. I think the main thing that would be sticking out to me is about blood pressure management. So some people that have had any sort of brain injury, they can damage the bit of the brain that helps regulate blood pressure. So they can have really high blood pressure, and that can become a problem for your kidneys. The other thing that sort of jumps out is if you have had a traumatic brain injury and are needing sort of painkillers or certain medications relating to that, some of them will affect your kidneys as well. Best, I'm going to say, I don't know if I'm going to sound really sort of patient pushy, like telling people to push their doctors, but I think for me, if I was seeing my nephrologist and I was worried about something and I was someone that had PKD, I'd be saying to them, is there anything that this would relate to? And I'd say the same for when you see the neurologists that deal with the brain injury. I'd say, is there any of these medications that would affect my kidneys? But the way for the two conditions interacting, there's nothing that I'm aware of that would directly interact each other. It's more you've got two conditions that have their own treatments that might not always work best for each other.
Thank you so much. Anything now is thank you. That seems to be the recurring thing that's popping in the corner of my screen now. Thank you from our community members.
I've enjoyed it. If people haven't got bored of me talking, that's the other thing. The only other thing.
I can honestly say I could listen for another hour. Every time we chat, we discover something else, and it's so valuable. And we really appreciate the preparation that you do prior to a presentation. It's fantastic. Thank you.